Dr. Larry brings you another segment of Did You Know?
Mood. A fancy word I like to use called disposition. The definition of that is a person's general attitude or mood. Tendency. A person's natural or prevailing tendency of spirits or leaning toward a particular way of thinking or acting. Quality of character. A quality of character, a habit, a preparation, a state of readiness, or a tendency to act in a specified way. Disposition, which I just defined, plays a role in how you approach the difficult situation if a hip or knee replacement has failed. Do you automatically blame the surgeon? Blame the parts, the materials used? Do you blame yourself? Try not to preload your attitude into a negative mindset. More so, if you are dealt this hand, approach it with a cooperative mindset, regardless for the reason of the failure. So somebody like Dr. Roedel, who we're going to hear here in just a second with our part 2 of this discussion, specializes in this area, can help you get the best outcome. So in the next segment, he will overview his very methodical process he goes through to properly diagnose failures and infections there at OSMS. Roll tape. I guess I'd like you to maybe describe the patient disposition, maybe some 1, 2, or 3 factors that you typically have to deal with, and maybe how you deal with those as well too. Or what are you seeing as far as patient disposition goes?
I think you hit that right on the nose. So I see all 3 of those type of presentations where some people they're coming to see me and they may feel distrustful or maybe abandoned by their initial surgeon. And they may be told that nothing is wrong with the joints or that nothing can be done. And so they certainly come having a lot of questions regarding that. I really try not to associate, to put any blame on an individual. Obviously, if I can see a reason that an implant is failing, in particular if it has a history of failure, I'll let the patient know that. But in general, it's hard for me to assign blame to an individual. If I wasn't there during the initial surgery, I don't know exactly what happened during their level of care. My intention is not to say that this is any individual's fault. We're usually in a situation where the patient is unhappy. They had high hopes that this joint replacement was going to make a difference for them, or maybe it made a really significant difference for a long time, and now something has changed. My goal is to understand why that happened and to move forward and make positive change. I think this is really important for your listeners too. There often is maybe a little bit of a sense of urgency that patients come in, they've been frustrated, they feel like they've maybe gotten pushed around or passed around and are not getting answers. And sometimes there's a sense of, I want to get in, I want to get this fixed yesterday. And I really encourage, and I encourage all the patients that I work with, that sometimes we have to be patient through this process. That I'm not in the practice of pushing anyone away or leaving them without answers, but often we need to do a period of data collection when I first see a patient. We're trying to really understand what's going on so that we can make sure we have a good solution that's going to fix the problem at hand. So sometimes that means we have to slow down a little bit, make sure we fully understand the problem, and then we can feel confident that the solution going forward is going to make them better.
Beautifully, wonderfully said. And the reason why I asked it that way is because it is and can be an emotional issue. And I think overall, if you're looking to get the best care in order for you, should this happen to you, and we're going to get into infections here, we're going to touch on that a little bit as well too, then if you just sterilize the mindset into it happens, and I always say sometimes it's great to have a fresh set of eyes on a case anyway, and Dr. Roedel would be that guy, that practitioner, that physician who decided to be the practitioner to be the fresh set of eyes in his fellowship and these kinds of cases. And as you hear him talking here, you can tell he's got a kind of a very slow, patient way of being able to handle in his description of these cases as well too. And that's, I got to imagine, coming up, you had to know, you're like, okay, I'm going to have to be real patient with these people. I'm going to have to be real mild mannered. And again, you're going to have to handle all ranges of types of emotions, and then just kind of maybe get that diluted down to, let's just get this thing fixed. Because the reality is what we have is clear the playing field. We got a prosthetic replacement issue here. Let's deal with it. Let's get it fixed and move on, which would be a good segue into our a little descriptive piece on the revision process. How does that work in your more practical sense? So maybe take your couple of 1, 2, 3, the revision process in a hip or knee. How does that look? And let's say maybe it's a glue issue. It's a placement issue. Describe that for us.
Mm-hmm. Going into the revision process, once we've identified a problem, so identifying the problem is the first part. That really is the most important part. Just doing revision for a joint because it's painful, if we can't understand why it's painful, then that revision surgery has really limited chance of success. So I spend that time to make sure we really have a good understanding of this. Once that diagnosis is made, usually the revision process involves identifying the implants that are already in there, understanding the sizes, and any compatibility that they have. And so my philosophy then is to just use the least invasive method to achieve the desired outcome for the patient without putting them at undue risk of this whole revision failing. So in some cases, that might mean an exchange of some of the modular components within a hip or knee replacement, changing out the plastic liner, for example, in a knee that is unstable because that plastic has started to wear. Sometimes putting in a new plastic liner will allow the patient to have the sense of stability in the knee, will help with that pain, and it's a much less invasive surgery than going and taking out all the implants and putting all new implants in. And in those cases, that's really not necessary to undergo that extensive of a surgery. So by understanding the cause, we can make sure that we're doing the appropriate level of revision. But in some cases, it does mean that we need to take out all the implants that are in there and put in a completely new hip or a new knee. To do that, I need to take out the implants that are in there. And so if those implants are still well fixed to bone, I have to use specialized instruments and techniques to loosen up that interface between the implants and the bone so that I can take it out. When I'm doing hip revision or knee revision, the bone really is a finite quantity. It's a finite resource. And so I really want to make sure that I'm respecting the bone and preserving as much as possible, because that really is the framework that the whole joint replacement is built on. And so I use those specialized tools and techniques to take the implants out. And then once they're out, the philosophy going forward is the same as when I'm doing a primary hip or knee replacement. My goal is to build the joint in a way that matches the patient's previous anatomy, so that it functions well with the soft tissues around, that it feels as close as possible to a normal joint. Hip and knee replacements can at times feel mechanical, and they are, but my goal is to try to minimize that as much as possible. And so I do that by really rigorous preoperative planning, looking at a series of x-rays and making sure that I can restore the soft tissue tension, the balance, back to what the patient had before the arthritis had really started to set in.
Excellent. And is there a common denominator of a type of component or something that you see that's a little bit more repeated versus some long tail or niche sort of cases? I mean, is there something like that where you see, okay, this is the typical thing that I see when it comes to a hip or knee? More with Dr. Gordon Roedel, hip and knee revision specialist.
Dr. Larry will be back in a moment.
Welcome back. If you're just tuning in, don't worry. we're just getting started. Dr. Roedel will discuss common denominators in why a hip or knee fails. Interesting to note, there are two eras in the last 20 or so years whereby there was a common issue with these types of prosthetic implants, then a change which minimized a certain failure, but in the post-era change, there are still some rare but common issues and problems and failures to deal with. Take a listen, roll the tape. Is there a common denominator of a type of component or something that you see that's a little bit more repeated versus some long tail or niche sort of cases? I mean, is there something like that where you see, okay, this is the typical thing that I see when it comes to a hip or knee, or is it varied?
Let me answer it this way. So an example would be that prior to the year 2000, the primary type of plastic that was put in the hip replacement to serve as the smooth surface that the metal ball moves against, that type of plastic had a known lifespan. And it was somewhere around 15 to 20 years. And the expectation was that after that time period, that plastic would start to wear and it would start to cause a reaction in the bone around the implants that would actually resorb some of that bone. And if nothing was done to revise the plastic, eventually it could progress to the point that the components like the shell or the stem could start to move within the bone and become loose. And so I do see a number of patients that present with pretty typical x-ray findings that I can see that plastic has worn over time. The position of the ball within the cup has changed. And sometimes even on x-ray, I can start to see some evidence of that bone thinning out around the implants. And so I can treat that in a way, if we can recognize it before the components have loosened, I can treat that in a way that allows us to preserve the implants that are in there, just change out that plastic liner, and perhaps use some bone graft to build in some of that lost bone, and really gets patients back to their normal activity in a much faster manner than if we have to take out everything that's in there and put new implants in.
And then so post that era or that time, is there now a different common denominator that you see, or is it just varied as far as that goes?
Yeah. So the after 2000, we started using a new type of plastic that has shown excellent lifespan. Even now, looking at 20, 25 years out, has not really shown evidence of loosening or wear of those components. So that's reassuring, and that's made that problem a little less prevalent now. The most common things that we see now tend to be infection. About 1% of all joint replacements get infected every year. And so sometimes this happens in the acute period right after surgery, and sometimes it could be years later. A joint that's worked and functioned well for years can become infected. So that's something that we have continued to deal with. We haven't really been able to lower the number on that. The other one that I mentioned earlier had to do with loosening of components. And over time, we've had some improvements in terms of the materials that hip and knee replacements are made out of. And they tend to be a little bit more stable within the bone than perhaps they were in the past. But we do see some instances, especially on knee replacements, where the interface between that bone cement that's used to hold the implant in place and the bone can start to loosen. And so there's been a little bit more investigation into using components that have a porous surface that the bone can actually grow into over time and is not dependent on that bone cement acting like a grout.
Got it. And as far as the infection goes, and since you seamlessly went right into that, which is what I really wanted to ask you next, and great job too. That's exactly what I was asking. So thank you for that. Okay. I'd like you to describe the presentation. This is almost where you have to be a detective, I guess, with a joint infection after a replacement. Examination, diagnostic tools utilized, and I what's echoing in the back of my head right now is like a patient that came in of mine, elderly lady, left total knee, and I had some issues with it. And she says 2 years later, she says, Dr. Lair, you're not gonna believe this. They found an infection in there, and it's been there for 2 years. And said, oh, wow, okay. And then she went on to describe the case, et cetera, et cetera. So now you're Dr. Detective. How do you find these elusive, sometimes joint infections? Obviously, some of them just scream right out and tell you by labs and presentation. But how do you go out and detect and find those and solve them?
Absolutely. So I think the most important key to be able to detect infection is to be thinking about it. And so I do have infection on the forefront of my mind. Part of that is because of the training that I went through. We took care of a lot of infected total joints. And so it's really hardwired into me to always sort of have that in my mind. Even if it's not, even if it doesn't seem obvious, it's something that I'm thinking about and checking for. As I mentioned earlier, one of the tools that I use, or one of the labs that I use, is a screening lab. I call them inflammatory markers, but specifically it's called a C-reactive protein and an erythrocyte sedimentation rate. We don't like saying all that, so we call them CRP and ESR, or just call them inflammatory markers. Anyway, those lab tests are easy to obtain, and if they're elevated, it raises some potential concern that infection could be present. Generally, if they're negative, we can put infection out of mind, but it's something that anytime I'm seeing a patient with a painful hip or knee replacement, I've got a pretty low threshold to draw those labs and check. If those labs come back positive, then I'm usually going to do a little bit more investigation. And typically that's going to involve trying to take some fluid off of the affected joint to do some laboratory analysis on. If it's a knee, I can usually do that in the clinic, and I can draw that fluid off myself. For a hip, to make sure that we're getting that directly from the joint space and that we're not putting the needle in the wrong spot, I'll usually have that done under image guidance. In either case, there's some specific labs that we can send off for, and this has been a pretty vibrant area of research recently, actually, trying to make sure that we're not running into these instances where someone can go with an infection for 2 years without it being recognized or diagnosed. And so classically, we can rely on cultures, sending that fluid to a lab and having it grown in a culture medium to see if a bacteria or fungus or something else grows out of that. There's also some lab numbers that are more typically associated with that. So looking at the specific types of cells or the number of cells within that fluid can be helpful. And then we've even started to do a little bit of genetic analysis where they can look for genetic patterns that are found, or DNA patterns found within certain bacteria, common bacteria that can infect joints. And if they can identify the presence of that DNA, then that can help us make a diagnosis as well. So we really have a pretty advanced armamentarium. Even with that, there are some cases that are borderline. So some instances, inflammatory markers might be normal, inflammatory markers might be elevated, but cultures come back normal, and one cell number comes back elevated, and the other is kind of borderline. And so then we need to make a little bit of a judgment call based on the presentation, the patient's symptoms, their imaging, and that other data. And so we've got some algorithms that exist to help us interpret that data, synthesize it, and try to come to a treatment decision, because the treatment for an infection is pretty extensive.
Yeah, and you answered that question how I was hoping you would answer it. Is you're hardwired to always think it, even though it's only 1%, and so unfortunately you got to be thinking about it 100% of the time for 1% of the time cases. So it's but since you're hardwired, it's okay because, like you said, it's always in the backdrop, and then some basic labs, and then some add-on labs if necessary, and then you obviously at that point in time, if it's a diagnosis, you go for it, which I'd love to get into that as well too, but we're going to circle back around to the revisions. I'd like you to go over 3 successful cases for us. We're going to go hip, knee, and infection, where you had a patient come in, and the same thing like you would see, like a patient presented with this hip replacement, and give us 3 successful cases. Start with the hip first, where you had to intervene in the outcome. This is going to be the icing on the cake. 3 successful cases of failures and infections. 1 case, a patient was at death's doorstep, and Dr. Roedel had to intervene. Stay tuned. This is the Dr. Larry Radio Show. We'll be right back.
We'll be right back with Dr. Larry. We're back with Dr. Larry.
Welcome back. If you are catching up with us, we're finishing up part 2 of our topic on failed hip, knee replacements and infections, then the revisions. Upcoming are 3 successful cases. This is quite compelling. Roll it. Give us 3 successful cases. Start with the hip first, where you had to intervene in the outcome.
Okay. This was an 84-year-old woman I took care of. She had a hip replacement that had been in place for 25 years and functioned very well for her for a long time. And unfortunately, she had a trip and fell, and she fractured her femur around the stem of her hip replacement. And it caused that stem to be loose and was no longer fixed to the bone. In addition, when we looked at her radiographs, we noticed that she had significant wear of the plastic liner, like I mentioned before, and that had resulted in some bone loss or osteolysis around her cup as well. It looks like her cup was still well fixed in place, but we weren't sure if it was going to remain in that position. And so with her surgery, I used bone graft to backfill the area around that cup. I did end up changing that cup out because it was no longer well supported by the bone. So new bone graft, new cup, and then I repaired the fracture in her femur using cables, and then placed a new stem in the femur. When I'm doing these type of revision surgeries, often the components that we have to use are a little bit larger than what we do in the primary hip or knee replacement. We usually need to try to gain a little bit more fixation within the bone, especially if some of that bone is no longer available. So after we had gotten these new implants in for her, I had her protect her weight bearing for about 6 weeks to allow that bone graft to incorporate well and allow her new implants to become well fixed to the bone. And after that 6-week period, I let her start progressing her activity, and she's now doing well. She's been able to walk without pain and does not really need a cane or walker to get around. And she's been very happy with that result.
Excellent. How about a knee?
So for knee, I love this story. This guy makes me so happy when I hear from him. So this is a 70-year-old. He had a history of a previous partial knee replacement. So his surgeon had just done a replacement on the inside or medial part of his knee for arthritis. And that had worked well for several years. But over time, it had started becoming more painful. It was limiting his activities. And he had noticed over time that his leg was becoming more bowed. And so he came in to see me. We got some x-rays, and it showed that the tibial component of his partial knee replacement had loosened, and it was actually causing the bone underneath that to start to collapse due to the stress. That was what was causing that deformity to his leg. So we did a revision surgery. We ended up using we used a titanium augment, metal augment, to build up that area where the bone had collapsed, and then used a metallic cone to help gain some solid fixation within that area of his tibia. And so after his surgery, I allowed him to start bending his knee and walking on that right away. Everything was stable, and he had a tremendous recovery. So he was back to full activities after 6 weeks. He's riding his motorcycle. He went to Sturgis last year, was doing yard work on his own.
Did you say you went to Sturgis?
He went to Sturgis, yeah.
Yeah.
So 8 weeks after I got a picture sent by his wife with him on his motorcycle, and just as happy as could be.
That's fantastic. The stuff that people, like you said, the 84-year-old lady, the 7-year-old guy, typically what you say is they'll say, Doc, I've got a lot of life left to live. I want to do it and be able to do pain-free. So snaps a picture on the bike, and that was his Hallmark card to you, huh?
Yeah, he's loving stuff. His wife regularly will give me updates and send me pictures of him doing yard work and doing things like that he really could not do before we did the surgery. And so he's very happy, and I love getting that kind of feedback.
Oh, yeah.
It makes my day. I know that I've made a difference. So.
Yep. So, and then for the final case, a search and find, joint infection, patient presentation. What did you find? Labs, etc. And then what did you have to do?
Yeah. So this gentleman, 76-year-old, he was a retired Marine and firefighter chief. And the first time I met him was in the ICU. He was on death's doorstep. He'd previously had his right hip replaced, and then his left hip had undergone replacement and multiple revisions by another surgeon. And at the time when I saw him, he was septic, high fevers, had bacteria identified within his blood, and had profound bacterial infection involving both hips, as well as some infection within the disc space of the spine. When I saw him the first time, he was so ill that it was hard for him to even move his arms or legs. And so, because of the severity of his illness at that time, how sick he was, we could not go forward with a full revision at that immediate point. We did take him to the OR to wash out his hips to help decrease the bacterial burden. And once he'd stabilized, in a staged fashion, we ended up taking out each hip, the left one first, and then a week later, we took out his right hip and put antibiotic-loaded spacers within his hips, something to essentially fill that space and provide some local antibiotic therapy. And so he was treated with a course of IV antibiotics for about 3 months. And once we had evidence that his inflammatory markers had normalized, he went off antibiotics. His levels remained stable. And so we did end up going back in, putting a new hip and a new new hip in either side for him, again, in a staged fashion. We gave him a few weeks between each surgery, saw him some recovery. And so because of the severity of his infection, we've kept him suppressed with an oral antibiotic. He'll take an oral antibiotic for the rest of his life. But I think that's a small price to pay for essentially getting his life back and still being with us. So he's got 2 hips that he can walk on now, gets around well, and reports that he's got really no pain in those joints. So he is really one of the great success stories that we've had.
Unbelievable. I was trying to pre-create a theater of the mind of what you may or may not say and pick out as far as a case goes. That's a doozy. That's unbelievable. I've seen a couple of cases like that just in my career overall. But like you said, just to be right there on the scene and be able to take care of it and handle it that way. Outstanding. Great job. And this is why, folks, I was excited to have him on the show. It's more of kind of a sensitive topic, but I wanted to bring it out right from Dr. Roedel, who deals with this and has the fellowship training in this, that it's something that can be handled. This is something that he has chosen as a career path to do, and he is working at OSMS. He's going to give out here the phone number in just a second again, and it's not that far away, as many of you know, in the broadcast area as well too. And as you listen to him through the interview, as patient as he was describing the process and what we had time for in this interview, he is going to take your case on and then maximize the time in order to fully make sure, diagnose the problem, and then do what's necessary without jumping to any conclusions as well too. So he is more than happy to review your cases if you have any of these situations going on. And I want to kind of just ask this one thing too. You also do just normal joint replacements, right? This is not just what you do all day long. Yeah, you'll do a hip or a knee, right? Okay.
I also do primary hip and knee replacements. I do hip replacements, do both an anterior and posterior approach.
Okay.
I do total knee replacements, partial knee replacements. So that's a very active part of my practice too, and I get a lot of satisfaction about getting people back to the activities they love after that.
Sure.
But I enjoy the opportunity to be able to take care of all of these patients.
Great. Well, Dr. Roedel, if first of all, it's spelled Roedel. So when you look him up on his profile, you heard how to pronounce his name correctly. So if you pronounce it incorrectly, it's your fault, people. It's Dr. Roedel. I actually had to ask him before we got on the show. So if listeners want to contact you for an appointment, they've got a case like this, either primary or possibility of some of the stuff we went over today. What's your phone number over at OSMS, and what's the website again?
Yeah, our phone number is 920-430-8113. And our website is OSMSGB.com.
Great.
And if you go to that page, there's in the upper right corner, there's a yellow button that says request an appointment. You can just click right on that and we can get you in.
Fantastic, Dr. Roedel. Thanks for coming on the show and walking us through all this.
Thanks so much for having me, Dr. Larry. Really appreciate it.